The next speaker will be speaking to us about SLE. In other words, it's lupus. It's Miss Alveta Reese. Miss Alveta, she have her LPN, which she received from Columbus Institute of Technology. She received her ADN from Chattahoochee Valley Community College, her BSN from Auburn, her master's from Auburn. Also, currently, she's in the doctoral program from Chamberlain College of Nursing. Miss Alveta is also a professor at Tuskegee. Next voice you'll hear will be Miss Alveta Reese.
Thank you so much. When she said she received her LPN, I said, oh my God, that's been 40 years. Are we going all the way back there? Good morning. First of all, I really want to commend Destination Divas. This is an awesome event. I pledge that next year I will help you promote. I'll make sure that we get people here because this is where people need to be in order to get the information that is needed. Now, I like to know who I'm talking to. I know I have a lot of nurses. I've seen a lot of nurses. But I want to know how many lay people are here. People who are just people who maybe have arthritis or not in the medical profession. Okay, thank you. It's important to me that you understand, and I am a teacher, so this has to be interactive. If you get quiet on me, I start singing that, 'cause I'm happy. That's the key to my students, that we have to talk, okay? So if you get quiet and you hear that, it's time to do some interaction. I am just ecstatic to be here and eternally grateful. My journey has been a long one through nursing, but it has just afforded me the opportunity to meet so many wonderful people, to learn so many things from patients, and now students who are keeping me technically savvy, because it's a different time than when I started, a lot different. So I am an oncology certified nurse, so I work in the cancer center where the infusions are done, work a lot with patients with rheumatology issues, and have really developed an interest particularly in lupus, fibromyalgia, all of those type of rheumatological conditions, as well as connective tissue diseases. So starting to look a little more into those things, because just like diabetes, these are diseases we're living with. These are diseases that there's no cure for, but the cure is life. We're living with these things, and we have to learn how to deal with these things. And then I'll have a few little commercials in here, some things that I have a little soapbox about. But so what is lupus? It's systemic lupus erythematous. It's a multi-system inflammatory autoimmune disease. What does that mean, really? It's something that affects your immune system. God designed our bodies so that we have a homeland security system. We have our own homeland security. It's always on, surveilling and see where's their trouble. It's the immune system. And so what it does is when it spots trouble, like this doesn't belong in here, it's not a part of my body, it calls for the army. And the army are cells that are part of the immune system. And they turn on and say, okay, you B lymphocytes, you T lymphocytes, there are lots of different kinds of cells that come to that area of trouble and say, let's take care of this. Phagocytes, all those things come and take care of the trouble, okay? So that's, in layman's terms, how the immune system works. When something happens and the immune system kicks into overdrive, Homeland Security kicks into overdrive and says, oh, I don't like that right there, but it's actually regular tissue. So for some reason, the immune system is affected and it kicks into overdrive. So it overexpresses or calls the army for no reason. So there's still tissue damage and tissue destruction. Does that make sense? Okay, so the healthy tissue, some of it that's affected are skin, joints, kidneys, blood, and neurological symptoms that are common. In this photograph, you'll see the classic sign of lupus, which is the butterfly rash that goes across the nose and over the cheeks. Some people get that very expressed, others do not. The one thing about lupus is there is no set pattern of disease. Lupus in me is different than lupus in you, is different than lupus in someone else. please stop me anytime and ask questions as well. So the cause is unknown. Very high incidence. We're seeing more and more cases. 2 to 8 persons per 100,000 of Americans, and approximately 1.4 million people will be diagnosed this year. That's a lot of people. Women are 10 times more likely to be diagnosed, and the highest occurrence is in African Americans, Hispanics, and Native Americans. A lot of genetic factors, hormonal factors. We think there are environmental factors, stress. How many people in here are stress-free today? All right. Let's give them a hand. We want to see y'all after class. But all these things do contribute to this disorder. Like we say, we don't know the cause. It does have a familial component. It's not hereditary, but we do see it commonly in families. It's multi-system. Like many of the other rheumatoid things we've talked about today, it can affect multiple systems. So this ache, that pain, at first, it's like, sometimes you get dismissed. I want to also stress something that Molly said. Communication is key with your healthcare provider. There are so many people, I'm also a parish nurse, and there are so many people who say, I went to the doctor the other day for this, and he put me on this medicine 3 times a day, and it made me feel bad, so I stopped taking it. Don't take yourself off your medicine. I mean, it's common. It is so common. Don't do it. Sometimes abrupting a medication, stopping it abruptly, does more harm to you, does more damage to you. So let's communicate to the healthcare provider. You gave me this medication. I've been on it 3 days. I'm having these or that or the other symptoms. And possibly they may say, well, let's decrease it, or let's do this, or let's do that. But not to communicate, and you go and pay that copay, and then you go to the pharmacy, pay all that money for that medicine, and you get home and you take it a couple of times, say, oh, this don't make me feel good, I'm not taking this, I just stopped it. So let's be more open about our communication. Let's talk to a healthcare provider before we do that. That's one of my commercials. The severity of lupus is highly variable. Like I said, it's no characteristic patterns, and organs are affected by multiple circulating complexes. Remember the army I talked about that came to take care of the whatever was going on in that area? Well, they form complexes, because it's just like if I'm allergic to a bee sting. Okay, then the immune system kicks in and sends things right there to that area. Well, we have these things there, but we don't need them, these complexes. So they're circulating and they're not necessary, and they're causing problems. The diagnosis, of course, is made by history and physical exam and specific lab tests. The ANA, and a lot of times in an inflammatory disease, some of the lab tests are very common. So an ANA is drawn, sometimes the antibody and a titer. The anti-nuclear antibody is present in 97% of patients with SLE. The anti-Smith antibodies are present in 30%. And it's a little more specific to, we're finding that the link is a little more specific to lupus and the anti-Smith. Now these other things, the LE-PrEP, we call it the ESR, and the C-reactive protein are elevated as well, but they're elevated in a lot of inflammatory diseases. Patients who present with any 4 of the following 11 criteria, that's used to make a more definitive diagnosis, because you've probably heard stories or know people who have had these symptoms for a while, and they've been going to the doctor and no definitive diagnosis is made. So this is the criteria. The rash, which is the butterfly rash that we talk about. There's also a type of lupus called discoid lupus, and it usually just affects the skin with a disc type rash, red patches. Photosensitivity. We just heard somebody talk about they thought their aunt was too cute to go out in the sun, but these people are very, very sensitive to the sun. The skin is very sensitive to the sun, and it's an unusual reaction to sunlight. Oral ulcers, oral or nasopharyngeal ulcers that the physician looks at. Non-erosive arthritis. So we see how these things kind of coexist. Serositis or pleuritis, that's pain in the chest area, pleuritic pain, or if the physician hears a pleural rub when we're listening to your chest. or evidence of pericardial effusion. Now that's having fluid around the heart. And that'll be documented by EKG or evidence of a pericardial effusion. Renal disorder. A lot of patients present with lupus nephritis. A lot of young people present with lupus nephritis, so they already have kidney damage at the time of diagnosis. And that's when they have persistent protein in the urine or cellular cast. Neurological disorder, seizures, or psychosis in the absence of drugs or any other cause of the seizure. And a hemolytic disorder, which is a disorder of the blood, like anemia, a low white blood cell counts. Immunological disorder, so sometimes, like I say, they coexist. The anti-double-stranded DNA or the anti-Smith or the anti-phospholipid antibodies. And then the anti-nuclear antibody, which is the abnormal titer of that in the absence of drugs. So any 4 of these 11 things will point us more into a diagnosis of SLE. Multisystem. When we say multisystem, this is multisystem. So this is a picture of a body, and it just shows you the systems that can be affected. Now, this doesn't mean that every system is affected, and it doesn't mean that every system is affected the whole time in everybody. But these are the things that can happen. With the skin, there's hair loss, alopecia sometimes. People start losing patches of hair. The butterfly rash we talked about, and the discoid rash we talked about. Palmar erythema, that's redness of the hands. Sometimes there's some peeling and skin problems with the hands. And mucosal ulcers in the mouth all the way down the GI tract. Excuse me. Neurological, patients sometimes have had strokes and seizures. Peripheral neuropathy, that's when you have that numbness and tingling in your hands and feet, and that's caused by a lot of things. Diabetics have peripheral neuropathy, so there are multiple things that cause some of these symptoms, which is sometimes why it's so difficult to make a diagnosis. Psychosis, my brother-in-law says I'm psychotic at times, so it has to be a kind of pattern with that. I have to tell you this. I had a dental appointment yesterday. I had a really bad, a procedure, and I have a problem with that. I have a real phobia with the dentist. So, of course, they knocked me out. And my sister took me, and when she brought me home, and she's tucking me in, and I looked up and said something to him. He said, "Oh, my God, you can still talk?" I thought they were going to get rid of that for a while. That's how we communicate. Sometimes cognitive impairment, start having some memory loss or inability to do things that you were able to do very fluently, like dealing with numbers or balancing a checkbook, or, there's just something not quite right there. We have cardiopulmonary symptoms, endocarditis, that's the inside lining of the heart gets inflamed, myocarditis and pericarditis, that's all layers of the heart being inflamed. Pleural effusion is when there is fluid outside the lung in between the lining of the chest wall. And that sometimes causes shortness of breath, especially if you're walking or doing some type of exertion and you're short of breath for no other reason. That can cause that. Pneumonitis is inflammation inside the lung tissue. And Raynaud's phenomenon. Raynaud's is very common in SLE. And that's where there is a discoloration and the hands are cold, the fingers are cold. You'll see these people with gloves on in the summertime because their fingers are really, really cold and discolored. They get cyanotic and bluish. The blood dyscrasias or hematologic, that's your anemia. Splenomegaly, your spleen sits right underneath your liver, and if it gets enlarged, there's some fullness and bloating there that you just kind of quite can't understand. And that's the body's way of trying to handle those abnormal blood cells. The spleen actually destroys those. So it gets engorged when we have all these abnormal cells floating around. And thrombocytopenia is when our platelets drop. Our platelets are responsible for the clotting of our blood. So what we start to see is bruising. We may see little red dots, petechiae all over us, and we bruise and bleed very easily. That's a sign that maybe our platelet count is low. In the urinary system, we talked about the kidney problems with glomerulonephritis. That's inflammation in the pelvis of the kidney. Hematuria is blood in the urine, and then protein in the urine. So you can't see the protein, but you can see the blood. So that is a sign and signal we need to look at. The GI tract, abdominal pain, diarrhea, dysphagia, nausea, and vomiting. Have you guys seen that Pepto-Bismol commercial where they're just singing diarrhea, constipation, blah, 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 blah? You think about that with all meds, all diseases. If there's an abdominal component, those are things that are very common. Abdominal pain, bloating, diarrhea. Dysphagia, though, is difficulty swallowing. And that's a distinct sign. If you have difficulty swallowing, something is wrong. You need to go, and you're going to go see about it because you can't eat well. Nausea and vomiting is very common, and it's caused by lots of things. It can be caused by medication, food, GERD. How many people now have GERD or are being treated for GERD? And we have young people being treated for GERD. I never heard of that when I was little. Do we have heartburn like that, or is it something they're putting in the food? I really think that. So lots of GI symptoms, but again, can be caused by other common things. Musculoskeletal, that's where we have the arthralgias, is what we call them. And that's pain and difficulty with joint movement, arthritis, myositis, and synovitis. When she was talking about, April was talking about the knee thing, I'm like, oh yeah, I think I need that now. I've got to do something, because we aren't supposed to just ache because we're aging. And reproductive, there are a lot of menstrual abnormalities that occur during lupus, patients with lupus. Okay, I think we talked about all that. Okay, I just did all that. All right, so 40% of the patients have the lupus nephritis, and I just talked about that. That's progressive. It's very important to treat that aggressively at the time of diagnosis, because it can lead to renal failure and dialysis. So the primary goal with all of these is to slow the progression. And lupus nephritis is treated with corticosteroids, cyclophosphamide or Cytoxan, and immunosuppressive therapy. And some of the, I'm very proud to see the reps here today, because some of those medications we'll actually talk about. In the nervous system, we see 15% of patients who have seizures from no other cause. Headache is a very, very, very common sign. But isn't headache a sign of everything? Sinusitis, brain tumors. I mean, you have a headache and it's constant and won't go away. You just don't know what it is. So that's something, again, that's common, but it needs to be investigated as we see this cluster of symptoms. Memory deficits, depression, and psychosis. We talked a little bit about that. Infection. Infection is huge in these patients because they are immunocompromised. Our immune system is not functioning properly, which leaves us open to infection and those things that can attack us. When Homeland Security is not properly functioning and there is a problem, then we don't have the resources we need to kind of take care of that. In the end-stage lupus patient, infection is a major cause of death. It's usually pneumonia, and there's a lot of febrile illnesses that indicates infection that goes with these patients. Now, when we talk about health promotion, it's very important. If you have any immunocompromising illness or you're being treated and you're immunocompromised, that you get an influenza vaccine, the pneumonia vaccine, but in these patients, no live viruses. The only time the flu vaccine is given live is usually to children. It's the nasal, intranasal, that's the live virus, but everything else is an attenuated virus. And I know people are still saying, I don't take the flu shot, it makes me sick. No, it does not. So we got to educate. We really have to educate so people will understand. Drug therapy, and if you'll notice, a lot of the drugs that Molly talked about with the rheumatoid arthritis are being utilized for lupus as well. The anti-inflammatories, the NSAIDs, the non-steroidals, that's the least, I guess, the least restrictive thing. So you want to start out mild if you can. Tylenol and Motrin for those mild aches and pains. The steroid-sparing drugs, methotrexate, she talked about that for rheumatoid as well. You do have to monitor the blood counts. That's important. The anti-malarial drugs, Plaquenil is one that she spoke of as well. We need to do frequent eye exams with that and report any visual disturbances immediately. The thing of it is, when we start on medications, we do read the side effects, and we should. But it's just like the commercials. You know, at the end they say, this drug may cause nausea, vomiting, diarrhea, da-da-da-da-da-da-da-da-da-da. The disclaimer that's somehow very true with new drugs. But what you want to look at is the incidence of the side effects happening. Commonly, it may cause this, this, and this. Rarely it could cause this, and this. So I think sometimes it's important because we're paying more attention to what we're putting in our bodies, but at the same time, we want to weigh the benefit against the risk. And that is a personal thing, but I want to educate you as to how to read those side effects. That doesn't mean they're all going to happen to you, and none of them may happen. So you want to be a little more educated about that. Corticosteroids, she talked about dexamethasone and prednisone. Again, you don't want those for long-term use. So what happens with SLE is that a patient will have a flare, like they'll start having symptoms and have the rash and have a flare and have a problem, and they'll go on the corticosteroid or the prednisone for a little while, and then we ease them off. Now that's definitely a drug that you cannot say, that made me feel bad, I'm gonna stop it. You're gonna feel a lot worse if you stop it. That's a drug that you have to taper off. And even if you get a Medrol dose pack, it's the same thing. You take 5 pills a day, 4 tomorrow, 3, 2. So you're tapering it down. Other immunosuppressants, we have cyclophosphamide, which is cytoxin, which we use a lot with the lupus nephritis. And then IVIG is the intravenous immunoglobulin. It will replace and replenish missing immunoglobulins responsible for immune sensitivity reactions. So a lot of times patients will be on that for SLE as well. Now, she talked a little bit about the biologics. A biologic response modifier, some of the newer therapies, they have a target. They work specifically on the cell itself. The cells that are in the body, they work specifically and they cause a certain reaction with that cell. They usually bind to a receptor right on that cell, which causes a better response in the patient. She talked a little bit about Rituxan or rituximab. Benlysta is a specific, belimumab is specific in starting to be used in lupus patients, and we're seeing some very positive results with that. It decreases the function of the B cells to form the antibodies in the body. Collaborative care in these situations is very important. We start, of course, with assessment, your physical, emotional, and psychosocial assessment. Very thorough pain assessment. Any disease or any life-altering situation that causes you pain needs a thorough assessment, okay? And that means that you have to be educated and to know what to tell the healthcare provider, like what causes the pain, does anything make it better, anything make it worse, what have I done to relieve it? Those kinds of things are very important in being able to treat the pain effectively. And then the effects on activities of daily living. When you looked at the patient with the rheumatoid arthritis in the hands, it takes collaborative care because that patient with occupational therapy will be able to maintain their activities of daily living, stay in their home. You just make modifications when these things occur. The plan of care has to be made with the patient. Molly said, we're sitting on this side and saying, okay, this is what you need. Well, you don't just go in and accept that. You say, no, that's not going to work for me. These are the issues that I have. Can we work together to find something that's going to be a good solution for me personally? Very, very important. Now, I put a lot of stars by this next one. Comply with the therapeutic regimen to maximize the symptom management. That means take your medicine. That's a very fancy way to say take your medicine. Constant communication with the healthcare provider is very important. And it is a team approach. And this is just some of the team members that we're privileged to be able to help you and care for you. We know the patient, the caregiver. Caregiver is very important because we tell the patient all these things and the caregiver cooks the food, or the caregiver is in charge of transportation, or the caregiver is in charge of these things, and the caregiver decides, no, we're not doing any of that, then your plan is just wash down the tubes. So social workers, therapists, dietitians, and national and local support groups are very, very important members and partners with collaborative care. Some of the things for health promotion, the sun, the stress, the vaccines, rest when we're tired. People who don't have rheumatological issues need to understand to rest when we're tired, because we don't. We just think we can just go till we drop. We want to plan for our activities, eat well, sometimes 6 small meals per day, plan low-impact aerobic exercises. And I always tell my students it's important to know what non-pharmacological methods work, the things you don't have to take as drugs. Tai Chi, gentle yoga, meditation, music, low-impact aerobic exercise. And right now there's a random control study of 1 year of planned physical exercise program in SLE patients that revealed that there was a significant increase in their quality of life among the patients in the exercise group. And there was no increase in end organ damage. And the patients tolerated the exercise well. Sometimes we think, well, I'm feeling bad, my joints hurt, I really shouldn't exercise. But the low impact, the water aerobics, those are wonderful things to help us to keep moving. And it improves our quality of life. The symptom management is priority, and we want to slow the progression. In other words, we want the periods of exacerbation and remission. We want longer periods of remission where we're not having to take the steroids. It is incurable, but early diagnosis and treatment improves the length of survival. And education is imperative. This is wonderful because it's education, and it's education on a level that hopefully everybody understands, that you're empowered, because if we get this education and take these pampers home and put them in our bag and put them in the corner, that doesn't help anybody. But we have to share, and we have to work on what we've learned here today. We want to take it and put it into action. Nursing management, all of our partners are very important as far as the collaborative team. SLE and pregnancy, a lot of times it's contraindicated, but it does require GYN and rheumatologists to work closely together. I've had friends with lupus who've had very severe lupus who have successfully given birth, and children are fine and they're fine. So counseling referrals are used in addition to medications. And this is a case study. I do it sometimes with my students. And this is a real person, 36-year-old African-American female nurse. She was a single mom of a 5-year-old, has a twin sister who lives in another town, and her fiance lives with her. Been diagnosed with lupus for the past 6 years. Then her health started to decline. The fiance moved out. She had 2 cook colleagues who were helping with the daughter and the finances, only able to work 2 days a week, forgets to take her meds, so she's starting to have some problems now. But the team got together, called a family meeting. She was in the hospital, and we needed to decide what to do. She wants to go home, be with her little girl, does not want custody, go to the father. We have to remember those psychosocial issues, they're there. The sister wants to move in with her, and social service wants her to go to the nursing home. This was very complex. It took us weeks and weeks to work with this, but we were able to get her home with home health, with some volunteers coming in, set up in the church. I mean, it was Cecil B. DeMille and the cast of thousands, but we did it. And she was able to be home with her daughter in her, with her custody. And it was very successful. It took all these people working together to make sure that her disposition was going to be what was best for her and her daughter. Now, this is a real study. 28-year-old Mexican-American female who's single, works as a manager for a hotel. She's newly diagnosed and initially treated with immunosuppressants and steroids. She is just in the course of her workup, connected to a local support group, changing to a healthier lifestyle. She plans for her daily exercise, healthy eating, and rest, and is doing well. She's about a year out now. So my whole thing is that we live with these illnesses, we live with these diseases. They can be life-changing, life-altering, and sometimes life-changing, but life goes on. So we take the information that we're given, and empowers us to make changes or to modify what we have to do in order to stay healthy. Our resources for today, the National Lupus Foundation, and I was actually going to go to this website. I want you guys to go to the website because it talks about research, the current research that's going on now, and that's why I'm so proud of the reps that are here, because some of these drugs are still, we've got some results, but they're still being utilized because we know that they're good. So we're looking at, can we combine these two to do this? So some current research things are going on there. And then an article from Nursing Standard and the Medical Surgical Nursing textbook. And then NIH.gov is the National Institutes of Health. and it has great patient resources. It's a governmental agency. It sort of oversees and controls most of the research that's going on. But it's a wonderful website, and you can just type in what you're looking for, and it just pops up all the patient education information for you. You just put in SLE or lupus. Why don't we end this and let me work with this so that maybe we can watch it during lunch? Is that all right? Are there any questions? Thank you for your time and your attention.
Ms. Reese, we want to present to you this token of our appreciation for you taking your time and speaking with everybody and sharing your information. It's from the Destination Divas, Eminent Solution, and New Thing in Power.
Thank you. That's pretty. Did y'all see it? That's beautiful. Thank you so much. Thank you. Thank you.